So we welcome you to this course on imaging and management of diabetic retinopathy. I am very fortunate to have some excellent speakers. Our president, Dr. Lalit Verma, is here. With me is Dr. Mahesh Gopalakrishnan, who is Mahesh, come there. He is both me and Mahesh will be the moderator. Then we have Dr. Dinesh Talwar, who will not be able to make it because he's not well. Dr. Bhuvan Chanana from Delhi. Dr. Vishal Agarwal, he is from Jaipur, and he is a prolific vitreoretina surgeon, has won many awards, including the Red Buckler. Dr. Lalit Verma, of course, needs no introduction. He's the president of AIOS. You know, he has guided a lot of us in many ways. So welcome, sir. Then we have Dr. Giridhar, who has been my senior, has been my guide in many ways. And he's from Giridhar Eye Institute, Kochi. Then Dr. Ritu Arora, who is an anterior segment surgeon, happens to be my wife. So she will be presenting on cataract surgery. And Dr. Rajiv Raman, who could not make it. So I'll be covering part of his presentation. So we welcome you all to the course. So this course is about, so this is the faculty, Dr. Lalit, Dr. Giridhar, Dr. Dinesh, Rajiv Raman, Vishal, Dr. Ritu, Bhuvan Chanana, Mahesh, and that's me. So this is the topics which we'll be covering, and we'll try to stick to time. Now, imaging in diabetic retinopathy, all of you know, is standard color imaging and fundus fluorescent angiography. We have seen over the last about 18 years when optical coherence tomography has come up. We started off with stratus, spectral, and it's gone further with the swept source OCT angiography. Then we have wide field imaging, fundus autofluorescence, microperimetry, and to combine it all with multimodal imaging. So let me just go through some of the photographs which I had taken about 15 years back, and they did convey a lot of message. So this was a diabetic retinopathy. This was clicked on a Zeiss fundus camera with the patient had 6 vision, and you could see some dot hemorrhages. And on an angiogram, we can localize that there was a small microaneurysm. So we were getting a fair idea of the foveal vascular zone. This was a patient with a 6-12 part vision, and we could relate it to a localized edema. And this was the time when I did not have OCT. This is in 2004, 2005. The first time I did get OCT was in 2007. And we could still see that there is a focal edema. And as I'll show with Dr. Rajiv Raman's presentation, they are looking at fundus photographs alone, putting in artificial intelligence and predicting what OCT will tell you. This is a picture of a broken foveal net with an enlarged foveal vascular zone, and this is to show you that based upon this focal leaks, we were able to treat with focal laser. So I'll just show you some examples with a 64 years old main diabetic patient. This is again old pictures, almost about 15-16 years back. Oral hypoglycemic, best corrected visual acuity is 6/24. The question is, would you do FFA and OCT? That time OCT was not available. We did an angiogram. So you can say that what an angiogram can show you, that we are not able to see the leaks on a clinical photograph, and if you are in a busy OPD, you may not be able to give adequate time. So therefore, when the patient comes to you the first time, an angiogram is required. Certainly, OCT is a must today, and you cannot go without it. And then all these areas of capillary non-perfusion in a severe NPDR cannot be made out without the help of a good angiogram. Then if the patient is allergic to fluorescein and you cannot do an IV angiography, there is the possibility of doing oral fluorescein angiography, but this is only possible on SLO-based systems. Like this is the picture on the Heidelberg, which we did many years back, and this can be used. So the take-home message is that angiography helps us to confirm the presence and extent of macular ischemia. It helps us to identify microaneurysms, confirms the area of NVD and NVE, demonstrates area of capillary non-perfusion. Now, here is a patient who had this was again a picture of 2008, who had thalassemia with a macular edema, underwent multiple injections of anti-VEGF, Tricot, well controlled metabolically, but had anemia and thalassemia with the hemoglobin not going beyond 9. So this is just to show you the OCTs of that time. We were looking at these graphs, we were looking at the elevation maps, and based upon that, anti-VEGFs were being given. This patient eventually underwent pars plana vitrectomy for a non-tractional edema, and she did well. And this is just to show you over a period of time, the reduction of macular edema. It was at that time that the various patterns of were described on the OCT of, so these were the patterns, the sponge-like retinal thickening, which means that in these cases, we will give an anti-VEGF, a partial thickness cystoid spaces, which now we believe that may require intervention by steroids, and full thickness cystoid spaces. And if you have a small neurosensory detachment, you must do kidney functions. If you have a sub-foveal CS RD, you must do kidney function in these cases. And in these cases now, as I'll show you subsequently with the better OCTs, the inflammatory markers or diabetic retinopathy. And then if you have a patient who has a tractional edema, so this was long time back, stratus OCT, we will now go back to the spectral OCT. And this led us to the various treatment protocols depending upon this. Once the stratus OCT came up, we were able to histologically identify all the 10 layers of retina, and then now we have swept source OCT. How does it help you? Some examples. So here is a 61-year-old male patient who had persistent diabetic macular edema despite multiple anti-VEGF injections, well controlled metabolically. But when we go ahead and do an angiogram, we realize the patient has multiple leaks. These are NVE, and there's a large area of capillary non-perfusion located peripherally. We went ahead and lasered this patient with a PRP. No more injections. Patient is sequestered without anti-VEGF injection, just to show you that when we combine two investigations of an OCT and a wide field angiography, we are able to treat these patients better, and we then reduce the amount of anti-VEGF injections that were required to be given. The OCT also tells us that if there is a vitreomacular traction, it tells us that there is an epiretinal membrane. So in these cases, it's important that a surgical intervention has to be done. An anti-VEGF may be given before surgery, but if you continue giving them anti-VEGF with a vitreomacular traction, the edema is never going to come down. Therefore, you must know what is the cause. And when we combine these pathologies, we can detect coexisting pathology, like in a wide field angiography with traction. We can make out that there is a coexisting pathology which helps us plan the surgical intervention better. We can also show if there is a persistent intraretinal cyst with a vitreomacular traction, and we can show hard exudates. You please notice that with the hard exudates, there is a shadowing behind. You can show the posterior hyaloid. You can show the hyperreflective foci or hyperreflective dots, which are less than 30 microns, and hence they don't have any shadowing behind. Now, the same patient in the left eye, we looked at, patient has large cystic spaces. You can see this, you can mark them out, show to the patient, has got multiple hyperreflective dots, which means this patient would be better treated with steroids. Again, this patient was treated with steroids, had a 25-gauge pars plana vitrectomy. At that time, we gave the patient posterior Tricot, which now I am giving suprachoroidal injections. Patient did well. Now again, with the enhancement as we go beyond, this was in 2014 when we started understanding about drill. So I have taken you from 2004 even backwards up to 2014, a 10-year story, how things have happened. And now we have been able to identify this is the disruption of the inner layers. This is called drill. So when you have drill, you can predict that this patient's visual acuity will not improve much. Then the drill was correlated with capillary non-perfusion, and Richard Spade had done a lot of work from which we understand that if we have two investigations combined, we can have a much better predictive value, which they showed that one could predict the loss of vision 4 months in advance based upon the OCT findings. Then what has come up is autofluorescence. And I think there are two types of autofluorescence which people should know. Mostly it is blue and green autofluorescence. Essentially the vessels appear dark because they absorb the light, blue light and green light. The disc appears dark. The macula appears dark because of presence of xanthophyll, and then you have autofluorescence because of the lipofuscin present in the retinal pigment epithelium. Now, just an example of a patient which was treated with micropulse laser. This is an OCT which shows a macular edema. On the autofluorescence, you can see some dark spots. As the treatment goes, the macular edema reduces and the dark spots have reduced. So you can actually follow these patients without an angiogram based only on an autofluorescence. And this is an upcoming technique. This is a paper of 2016 which is now trying to predict that even when the color fundus photograph is absolutely normal, autofluorescence indicates changes. So these patients who have these changes, if they get controlled well metabolically, it's a good idea. If you could read this paper, it will be very useful. Then came up the utility of wide field angiography, and it's been shown that all of you know that there is a 7-field ETDRS recording, but it was shown by Ailo et al. From the Jocelyn Clinic that in 10% cases the peripheral findings are missed. Hence, the wide field angiography is useful, and as an example, I'll show you this case, which was operated for a vitreous hemorrhage with a very bad proliferative diabetic retinopathy. Patient, we had to inject silicone oil. Patient's visual acuity improved, but then patient had a rebleed. We gave a vitreous lavage, and after the vitreous lavage, we did an angiogram. So if you see here, the difference between a wide field angiography and a normal fundus photograph. A normal fundus photograph only shows you so much, while a wide field shows you so much. When we did a wide field angiography, we could pick up the NVE, we could pick up large area of capillary non-perfusion, which basically means if we laser these areas, these patients will not bleed. Similarly, the other eye, so this patient now has been lasered, is doing well. And the other eye of the patient, you could see there's a large vitropapillary retraction. There were areas which were NVE which was present, and you can see the angiogram with the NVE. Again, if we only do a normal fundus photography, all the peripheral lesions will be missed, just to show you the difference between the two. So these lesions were picked up, lasered, and patient is doing well. When we combine all these things, we get the multimodal imaging, which is we get a fundus autofluorescence, microperimetry, fundus fluorescence angiography, and OCT, and that actually helps us in treating these patients better. So the take home is imaging is helping us understand the disease pathophysiology and hence plan our treatment and preempt the complications. It allows us to communicate with the patient better. We can show them what they have. It is also helps us that way medico-legally. It helps us to assess the treatment benefits and share our results the way I'm sharing with you today. That way the learning goes on, and hence it's a very good tool. Thank you, and I will next call sir. We have Dr. Dinesh Talwar's presentation, so should I go ahead and finish it off? Okay. So Dr. Dinesh is not here. I will present his. So Dr. Dinesh had sent me his presentation. The best would have been, nobody can replace DT the way he explains, but I will do whatever justice I can. So Dr. Dinesh was presenting on role of anti-VEGFs in diabetic macular edema and proliferative diabetic maculopathy. There are 11 take-home messages. So this is what we know, that there is NPDR, maculopathy, and proliferative diabetic retinopathy, and the approach to the patient is that if we do not have a retinopathy or an early NPDR, we must do a medical treatment. If you have a diabetic maculopathy, PDR, we have to treat these patients medically by intravitreal injections. All these patients must be controlled metabolically well. We must give anti-VEGF injections and we must treat them surgically wherever required. So the message number one is it should be a multi-pronged attack. We must change the internal milieu of the patient. That means we must control them by good metabolic control, a good lipid control. And so this means you have to have target values. And it's generally the American Diabetic Association has given very low values for HbA1c, but generally we say it should be below 7. They say the target value of 6.1, but that sometimes patient gets hypoglycemic attacks, and then we must control hypertension, nephropathy, and we must control the lipid profile, especially the LDL. In a diabetic macular edema, it's important to identify whether it is a center-involving or a non-center-involving diabetic macular edema. A center-involving diabetic macular edema must be treated by anti-VEGFs. And how do you know that? If it is between, according to what ETDR says, 500 to 3000 micron, Dr. Dinesh believes it should be from 750 to 3000 micron. So if it is from 750 to 3000 micron, you can do it with focal laser. If it is within 750 micron, one must treat with anti-VEGF. A lot of protocols have come up with the drca.net, and protocol T basically tells us that once we give, it was comparison of aflibercept, ranibizumab and bevacizumab, which showed that during the initial treatment, there was a dramatic response with all three drugs, maximum with aflibercept. But over the period of 2 years, the response of ranibizumab and aflibercept came closer, but there was a statistical difference when they were compared with bevacizumab. It also showed that patients who had a visual acuity of less than 20/40, the benefit was much higher with aflibercept. So the take-home message is, if you have a patient with a vision of less than 20/40, the choice of agent is aflibercept. But patients who have a better vision at 20/40, you can use any agent. If the patient cannot afford anything, I think Avastin still is a good option, and I think it should be done. You should not allow the patient not to have any injections. It was also shown that patients who have a good prognosis are the patients who respond within the first 2 or 3 injections. Many times they may not need a third injection or a fourth injections. Therefore, you must try the initial loading doses, and if the patient responds and does not need third injection, that can be avoided. That's what Dr. Dinesh is suggesting. And those who do not need injection at month 3 and month 4 are generally a better responders. Now, protocol T also associates the reduction of central subfield thickness, and it's been shown that the maximum response again occurs with aflibercept, and minimal, and the bevacizumab is least effective. But please understand, an intravitreal injection of bevacizumab is always better than no injection at all. So you must continue anti-VEGFs if you see continued improvement. And if patient is not responding, the alternative is, if you were on Avastin, you could shift to another anti-VEGF agent, or if you find the inflammatory biomarkers like cystoid spaces, hyperreflective dots, or neurosensory detachment, then you shift to steroids. And then patients with a distant visual acuity of better than 20/40, or patient has a visual acuity of n/8, it's better that you must also add nipafenec drops, control them medically, and it is also possible that you can monitor these patients, and if the patients are deteriorating, then you can initiate anti-VEGF injections, which has been again shown by protocol V. Decrease of near vision or decrease in distant vision, both are indicators for the anti-VEGF injections. Now, with regards to the proliferative diabetic retinopathy, it's been shown that anti-VEGFs work well, but please understand, a pan-retinal photocoagulation gives a permanency to the treatment. Of course, there is a loss of field, but it's been shown that with anti-VEGFs also, on a 5-year follow-up, which is quite dramatic, that even with anti-VEGF injections, you can have a loss of field. So the role of anti-VEGF agents in the treatment of proliferative diabetic retinopathy is We normally use it before surgery. It helps us do the surgical intervention better, peel off the membranes better, and combining the two is possibly the best approach. So, ladies and gentlemen, judicious use of anti-VEGF agents as part of the multi-pronged attack can definitely help to preserve and improve visual function. I hope I have done justice to what Dr. Dinesh had to say, and thank you all very much.
Thank you. Should we have discussion immediately or one or two questions?
Yeah, whatever that's what I wrote in the beginning. We should have interaction.
Interaction.
Of the Dr. Dinesh. Can you please put it on?
Also, any questions? Also, one or two from the audience we can take. Yeah.
So I don't use subtenon steroid anymore. I use only.
No, no. Actually, since intravitreal is so, I mean, we are used to it. We are not using the subtenon that frequently.
Yeah, because if you look at the amount, the dosage which is given, a subtenon injection, you generally inject about 0.75 ml. 0.75 ml is almost about 15 milligrams. And
Yeah, one
yeah.
1 ml.
1 ml is.
1 ml or 0.5 ml will be.
Yeah, yeah. So you give 0.5 to 0.75 ml. By intravitreal, you give 0.1, which is 4 milligrams. I use suprachoroidal, so it's different. There, the problems don't come up. Yeah, Dr. No, no. What he was trying to say, if there is a flat NV, you could laser it before. If there's a raised NV, it's important. Yeah, yeah. So with the macular edema, I do not know what your choice is. I generally give an anti-VEGF and then we go ahead surgical. Yeah. Correct. Correct. So then,
Subtenon with problem.
correct. Any questions from the audience? It will be good if you interact, ask one or two questions. We'll feel satisfied. So next is Dr. Bhuman. He's speaking on role of lasers in diabetic retinopathy in the anti-VEGF era.
Thank Dr. Ajay Arora and the whole AIOS team, especially Dr. Lalit, for allowing me to present this. So I'll be presenting the role of the conventional and dual lasers in diabetic retinopathy. The role of laser has really diminished in recent years and it has got very limited indications. I just try to highlight those limited indications because now we have got excellent new treatment options. So I think laser still plays some role, some important role in the management of diabetic eye disease, despite the popularity of anti-VEGF agents. So for decades, we all know that laser photocoagulation was the first line treatment for both proliferative diabetic retinopathy and diabetic macular edema. And after the advent of anti-VEGF agents, which have shown superior visual results and more rapid improvement, the role of lasers have become much more reduced. So just to briefly highlight, so this was the initial times when laser was used, which was the on which the treatment was based of high risk proliferative diabetic retinopathy with the guidelines from the DRS study. So they said that if these were the indications, then a PRP laser to be done, but we used to do it even when there was a mild presence of a NVE. Since a worst scenario, I think doing a laser is the best option because the patients are usually lost to follow-up. So PDR, we all know, can lead to severe complication, and hence laser is very important still for the management of PDR, despite anti-VEGF agents and various studies saying that you give monthly injections of anti-VEGF agents, but these are not feasible. And once you stop these treatment, then probably there can be a recurrence of the PDR, which can lead to all these complications of vitreous hemorrhage, atraxial retinal detachment, a combined detachment, or neovascular glaucoma. Hence, PRP still remains the mainstay of treatment for proliferative diabetic retinopathy. How to do a PRP? Very briefly. So usually we need approximately 1600 minimum burns, which is done all over the retina, done over a period of 2 to 3 sittings. And the laser settings would be around 0.2 duration of seconds with a power of more than 200, and they should be separated by half burn. So the main principle is to ablate the ischemic retina. However, with the conventional PDR, there are some disadvantages. That is, it leads to patient discomfort. It can lead to loss of accommodation. It can lead to disturbances in the night vision. If you do aggressive laser, it can lead to a choroidal detachment also. It can lead to exacerbation of the diabetic macular edema, and hence we have to take care of that before, if there is a diabetic macular edema, injecting an anti-VEGF agent. Decreased peripheral vision, color vision, night vision is there, but still PRP remains the gold standard for the management of proliferative diabetic retinopathy. Another new concept is the targeted retinal photocoagulation, which can be done in early stages of severe NPDR or PDR. With the help of wide field angiography, you can locate the areas, the peripheral areas of the ischemia, and a targeted laser can be done. So these will prevent all the complications because of a pan-retinal photocoagulation. But in these cases, a follow-up is very essential, since there may be further ischemia due to the blockage of the microvessels, which can lead to formation of neovascularization. So this is a very interesting concept. Studies have been done, I have tried it, and it's very effective in reducing the VEGF load and also taking care of the macular edema sometimes. So the other are the modern scanning laser photocoagulation techniques, like which we call the Pascal was there, now a simple pattern laser. Other companies have also come forward. It also uses the same 532 wavelength. And in this we have got patterns, various patterns are available in an arc, a grid, or a bigger rectangle, and that reduces the time and increases the patient comfort since the duration is increased. So as I said, it reduces the time, increases the patient comfort, and histological studies also show that it leads to less collateral tissue damage to the inner retina due to the longer duration. So the drawback is, since there is less tissue damage, it also is less effective as compared to a conventional PRP. So if you're doing a pattern laser, it's very important again to observe these patients, since there may be some presence of ischemic retina may be presence there may be persistence of the NVE, which requires probably much more intense laser. The other is the Navilas, that is a image guided laser therapies. And that you can, with your all your fundus photography and your angiography, you can set a pre-guided picture, and with all these, the laser is done by image guided therapy. I have not used it, but this is again new. This is again a new advancement. Again, the role of lasers have reduced, so this is not very popular now, but it's very effective for management of diabetic macular edema. If you've got these images of infrared images, colored photographs, and fluorescent angiography photographs, you can just reproduce them, and the laser is done in an image guided way. So it can be used for both for the management of proliferative diabetic retinopathy as well as DME. So as I said initially also, that in the protocol S, they said you give monthly injections for the management of PDR, but this is not viable either financially or because of the medical constraints in our scenario, because patients are usually ill, they can't come, and if the patient will miss their injections or stop the treatment, it can lead to severe complications. Hence, for PDR, PRP is still the gold standard. Now coming to diabetic macular edema, we all know that it's one of the most leading cause of legal blindness in diabetic patients. So again, coming to the conventional, as I said for PDR, ETDRS was the one that defined the CSME. Now we basically just use OCT to see these center involving DME, and we have forgotten this term CSME, which I think is very important because there is presence of parafoveal just adjacent to the edema is also present, which has to be treated. So laser definition was done by that. So it prevented the loss of median vision loss by 50%. So the drawback with the lasers in DME is it does not help in the improvement of vision with macular grid, and here anti-VEGF plays an important role. So there is also a risk of vision loss from the central scars which are created because of the laser. The laser gradually expands over time, and these were the limitations over the macular grid, which I think we all have stopped doing after the advent of the anti-VEGF agents. So these are the newer drugs. I'm not going into the detail of this. These anti-VEGF agents will be discussed by the other speakers. So these are the new drugs which are now used for DME, and laser, conventional laser has a very limited role. So protocol T is one study which even Dr. Ajay Arora mentioned, in which showed that aflibercept as well as ranibizumab had very superior response to DME. But why am I highlighting this? Because even in these cases, after 24 to 48 weeks, some patients required focal laser. So focal laser is very important for diabetic macular patients, even in today's scenario. It is like a rescue laser in which you can do a fluorescent angiography later, and wherever there are those focal leakages which are present, those pinpoint red areas, those can be laser. They not only reduce the macular edema, but they will also reduce the number of injections which are required in future. So these newer modalities of lasers, these pattern laser and Navilas, can also be used for the management of DME as for management of PDR also. Selective retinal therapy is another new technique in which the very microsecond pulses of duration of laser is short. It creates a high temperature which is confined to the RP cells only, and hence the collateral damage is very less. So again, this is a newer technique. I have not used it. This is a newer technique, so I just wanted to mention it before I end my presentation. The other is the sub-threshold diode micropulse laser. Dr. Ajay Arora uses frequently. I have not used it, I don't have it. So it is another novel technique which causes very less collateral damage because the near infrared diode laser is confined to the RP layers, and there are microsecond laser pulses which are present that do not cause any collateral damage and help in management of DME. So both these techniques are very similar. They have a very selective role. There is no visible scarring or intraretinal damage there. But however, again, I'm just stressing for DME, the mainstay still the treatment is anti-VEGF agents, and then steroids and probably focal laser as a rescue therapy or to reduce the number of injections. So just to summarize, these are all the laser techniques which can be used for proliferative diabetic retinopathy and DME. The conventional laser was there, the pulse duration which I have just discussed, and all the advantages and limitations I have also discussed. So just to conclude, so laser has now become the second line treatment for center involving DME. However, for parafoveal DME, it's very important. Laser still has a very important role in management of DME, and very important to highlight, it's very important to control the systemic status for management of diabetic macular edema, proliferative diabetic retinopathy. And laser takes some time for its effect to come. So if you're doing a laser, then you should not just hurry for the final results. So when should laser be applied as a primary treatment? When there is a non-center involving DME. If a patient has got a recent stroke or a heart event of less than 2 months, then probably anti-VEGF are contraindicated. And even if the patient has glaucoma and you can't give a steroid, then probably doing a focal laser or a sub-threshold laser, I think are often the choice. So the take-home message is the laser is still the gold standard for proliferative diabetic retinopathy. Newer laser patterns are available which are more comfortable. They save time. Anti-VEGF and steroids are the ones are mainstay of treatment for diabetic macular edema, but laser still has a definitive role. And the selective laser therapies, they are the ones which cause less collateral damage and they're not visible, but however the use is very limited. So thank you all for your attention.
So there is a term which now is being frequently used as MMG, which is the minimal macular grid. So there were three terms which I want you people to take back home. Is the ETDRS protocol, a modified ETDRS protocol, and minimal macular grid. What is the major difference? ETDRS protocols, microanalysis were blanched with a color change. modified ETDS protocol, this was not a target. And MMG is where there's a minimal credit. They say don't even bother about microaneurysm. It is like almost like a continuous wave laser with a reduction of power. But I do not know. I do not know what Dr. Lalit, Dr. Vishal would feel about it.
Exactly in the same aim is we just if we have a paraphobia.
Have a mic. So these are terms which you should be aware of. And what can you pass on a mic, please?
It's very good to be aware of these fancy terms, but believe me, none of them has stood the test of time, and we are very keen to import such terms from outside. But they do not. You see, even micropulse itself has not stood the test of time, and does it? Ultimately, what has stood the test of time is the standard, for which decades of experience is there. Decades is not 1 or 2 years, but it decades. Since the 80s we started doing, and patients come still 6/6 when we are done. And fancy terms is good to know as far as knowledge is concerned. Google is concerned, that's perfectly okay. But realistically, practically speaking, practical application is not there. No.
So actually, I think the main aim should be just if there is a paraphobia, like that is a leaking microaneurysm, we just have to close that.
Yeah, Dr. Bhuvan said very clearly, very important message. Non-central involving media, go ahead and do laser.
That is from 750 to 3000 is all focal
Wherever
laser.
it is safe. Obviously, you don't
it's
burn
safe.
the macula. Nobody is foolish enough to burn the macula. Why should you? But even in center involving macular edema, you should you give injections, but after a couple of months or 3-4 injections, you do a FA and find out few leaks. Some of them may be in the fovea, or some of them outside. You laser those outside, and it will reduce the number of injections.
The other thing which you must understand is center diabetic macular edema, where the microaneurysm is within the center versus the microaneurysm which is away from the center, but the leak is traveling down and causing center involvement.
Because remember, it's a saucer shaped structure, and it's a gravity element. So once you are peeling, also this macula, the fovea or this very center is slightly deeper than the. It's not a flat structure. It's a saucer like. So in any case, this edema will gravitate down.
You are using micropulse laser for center involving also?
No. In case patient is having center involving diabetic macular edema, we have given anti-VEGFs. So we have been using micropulse laser, and the number of injections come down.
Significantly. The problem is number of injections come down because in diabetes it's a multifactorial disease. A lot of things get controlled. Diabetes sugar gets controlled, hemoglobin gets controlled, blood pressure. So all these things have a relevance. So unless and until we have a long series of controlled trial between say micropulse and this, all the other parameters.
So now that is being started because the micropulse laser group has been formed internationally. We standardized the protocol which is being done, and that protocol will be used by all. Otherwise, people will be using their own personal protocol. Once the standardized is, then we'll have within 1 or 2 years we'll have better data.
So I think for DME, everybody will still have their own.
Yeah.
We next have President Dr. Lalit Verma. He will be presenting on vitreoretinal surgery in PDR, timing, technique, and tips. You have to say that.
Having me here, and I must congratulate Bhuvan for highlighting that laser is not dead. Laser is still alive, and PRP is still the mainstay of PDR. And we all of us have, if not thousands, hundreds of patients following up for last maybe 4 decades who are doing 6/6 and doing excellently well. And all this, injections are trying to push away the utility of laser. And remember, these are all, studies which want to establish the role of anti-VEGF in every kind of disease. And this non-inferiority trial also concluded that provided you can give repeated injections, it is non-inferior. But remember, the cost economics, which I was talking to Vishal, is not possible here. In a patient of PDR with HRC, you keep giving injections. To me, it looks absolutely stupid and nonsense that you keep giving injections in a patient of PDR. The only condition where I may agree is patient like this. You You see this patient, one-eyed patient PDR, has good vision. You see the macula is so healthy, but the front is huge. Good vision, massive fronts. So here if I do laser, there's a possibility of precipitating a TRD or causing a macular edema, and this is reasonably close. So I gave one injection and immediately after that started lasering. Did not give more injections. And you see this this is another patient who has again one-eyed patient PDR, but huge fronts very close to the macula. So here lasering is not easy because this is very close. So here again gave injection, and you see the effect of anti-VEGF is to shrink these vessels, the new vessels, and then ultimately, believe me, you have to depend on laser only in PDR. So laser is the mainstay irrespective of what any company says in management of PDR, and good laser, properly done laser goes a long way. You see, issue is of repeated injection cost, visits, which is huge. In West, people are insured, so they may, do it, but here you can't. What I would say is early vitrectomy in such patients, as soon as you notice some repeated hemorrhages or TRD, go for early vitrectomy, good laser, long-term results will be there. You have to calculate aggression during vitrectomy. You may not show surgical heroism while doing vitrectomy. So I just come to the main talk about vitreous surgery. Again, this patient, all membranes do not require surgery. And please do not give injections in patients of vitreous hemorrhage if it is unlasered. See, if it is a vertical patient you are following up, then it's okay. But if patient has come for vitreous hemorrhage not being lasered, I do not advocate giving in this injection at all. Whatever, because the theoretical basis, a lot of people may argue that will shrink the vessels and hemorrhage will resolve, but believe me, that is not the ultimate cure of vitreous hemorrhage, especially in unlasered retinas. If lasered you have done, say, good PRP has been done, then if there is a small ooze, you can still give. But simultaneously be prepared for VR surgery, because there have been reports, and personally also you have seen, if you give these injections, you may precipitate a TRD also. So this patient, we haven't done anything in fact except lasering, because the predominant RD is nasal. This patient, on the contrary, you see fundus picture is so horrible, and there is anterior segment neovascularization also. So you give anti-VEGF but simultaneously do surgery. So indication of vitreous surgery have evolved. Hardly we get patients of vitreous hemorrhage nowadays. What we get is TRDs, macular TRDs or combined detachments, and also non-responsive macular edema, which has been shown. So I'll show you one or two videos. This is a patient who has had vitreous hemorrhage. So you do a core vitrectomy initially, and gradually, if the retina starts becoming visible, identify the culprit. Culprit means from where the blood is. Here you see there's a massive front of the disc. So you truncate this, and then sometimes this may bleed, sometimes may not. If there's small ooze, I think you can in the meanwhile do peripheral vitrectomy, go all 360 degrees, and don't try to take out the probe too often. And you can take out with the help of suction this loose blood which may happen during surgery. That this can be taken out with the help of cutter alone. The health of the macula and disc immediately you should see. If those two structures are very good, believe me, don't pull too much. And then you have to do laser. Keep lasering. Surgical time in this patient was around 10 minutes or so, but laser took me around 15 minutes or so, because I'm very fond of lasering in a linear fashion, not to have any skip areas anywhere. So this patient hardly had any traction anywhere. It was a plain clear-cut patient of vitreous hemorrhage, and the reason I did surgery was because this was the 4th episode of vitreous hemorrhage in this patient. And this patient did not require any gas also, only air fluid exchange was done. And this is the picture at the end of surgery. The reason of showing this video is that ultimately you have to depend on laser. And laser is the ultimate savior for these patients. And this is the end of surgery now. So this is the post-op result. Not moving here. So here is a collection of one or two videos. This is again a patient who has had vitreous hemorrhage. Again, the main aim is to first to do core vitrectomy and then try to make a hole in the hyaloid if you can. Once you make a hole in the hyaloid, the entire retrohyaloid blood starts coming out if it is a loose blood, and this will show that this entire loose blood starts coming out, and you can employ a suction, gentle suction. Don't pull too much at this time. Sorry. So once remove this loose blood, do not allow this blood to collect over the macula for a very long time, because it will form a membrane, and then sometimes you will have to deploy a forceps to remove this. And once that has been done, identify the culprits, truncate all these fibrovascular proliferations. And believe me, no two diabetic vitrectomies are same. So much of blood has come on during vitrectomy. This is iatrogenic issue, and remove this with the help of either only suction mode, and after that pay attention to rest of the membranes. Like in this patient, in the just adjacent to a disc, we could identify. Do not pull too much. In this patient, it was a loose membrane, so I did a traction test. Just pull it up. If it is coming, well and good, but don't pull too much. And again, as I said, you have to depend on laser. This patient, again, we did a lot of laser here. This was a patient of diabetic macular edema, because I will skip this because this has already been covered. Here we did peel the ILM in this patient because this is a tractional kind of diabetic. This is another patient, who was undergoing vitrectomy for a TRD. Here the reason I am showing this is there is a dense cord. Although macula is very good, initially I thought there's no, because it is so thick, but ultimately with this cutter and suction alone, we could remove this. I did not take it to the entire periphery. I just truncated it and then diathermized the edges of this, and then did the airflow exchange. So this was another patient of diabetic vitrectomy, where the initial steps were very convenient to do and not very difficult, including the base dissection, which may be required. But what was bothering me and why I'm showing this video is that sometimes you see this traction, which was the left eye but nasal side. So the approachability of the instruments was not good. So what was done was they shift your infusion cannula. Infusion cannula now comes upper nasal. You shift your entire chair on the temporal side. So what was nasal now becomes inferior, and then you can the maneuverability of the instruments becomes easier, and this entire fibroscopic proliferation then was with the help of cutter suction alone only would be taken care of. And once this was done, then again we shifted back the instrument to the same place. Sometimes there may be combined detachment in diabetics. 2 minutes more, no? Just 2 minutes. Yeah. So this was a patient who had a combined TRD. So sometimes you can see this break here on the nasal side. It may be very difficult to find a plane also. So here what I am doing is you are just creating a mini kind of PVD, because I could not find plane. And after that, once it's slightly lifted with the help of forceps, then the insinuation of the instruments in between the healthy retina and this membrane becomes slightly easier. So I have segmented this, and we will do this process everywhere in between the two, bullae of detachments also. You take it, but with least possible suction, try to truncate all this. You have to be very slow, not pulling this too much, otherwise you will create a break. Remember, all these fibrovascular adhesions are vascular and they are densely adherent. So if you pull too much, either you will cause a break or a bleeding there. So you have to be very, very patient in this. So then I injected PFCL. You notice all this segmentation which has been done. So same patient, then we, because there are a lot of prolif still there, then we shifted to bimanual surgery. And bimanual surgery in diabetes is very, very useful, believe me. with forceps in one hand and scissors in the other. Curves is the best kind of instrument, and you just lift it and then cut those fibroscope pegs slowly, gently, without causing a break. You have to lift it and pull slightly. Then only you will be able to identify the adherence point. Have to be done all through 360 degrees of the posterior pole. Sometimes you may have to exchange your hands between scissors and forceps, and you can employ scissors by for doing some delamination also. So after removing the entire structure, which was not possible with the help of cutter, because if you keep only the cutter, even 25 gauge cutter, you may have more complications. And with advantage of bimanual is adding precision. Actually, you can add very precisely see and cut. So bimanual surgery, even in this small gauge vitrectomy, is still very useful in diabetics because complications are less and precision is higher, and better hemostasis also. This is the result of the same patient which I had shown. The other eye of the same patient also is here. This is another patient who had bilateral TRDs. So both eyes, the upper one and the lower one shows pre-op and post-op OCTs also. So a couple of more examples where this bimanual surgery has yielded good results. Bilateral, here again left eye, right eye both. This was the same patient which I showed previously, presented with PLPR vision. Fortunately recovered 6/18 only. So thus to summarize, in all these complicated patients of PDR who require surgery, pre-op you have to ensure a couple of things. The metabolic control has to be good. Plus also ensure that your diathermy lasers are available, because hemostasis is a very big issue. And you have to assess these patients from the point of view of pupil diameter, rubeosis, lens status, and because normally we try to preserve lens in these patients, and a good B scan. Also fitness and anesthesia consultation should always be done, because anti-VEGFs are required in a lot of these patients, especially with the angry looking proliferations are there. And I like to stop blood thinners in all these patients at least 3 days before, especially if they are on two blood thinners like aspirin and clopidogrel. But metabolically stable patient is always welcome rather than, and if the patient is on dialysis, then in between 2 dialysis days you should try to do surgery. It's not a simple vitrectomy, no two diabetic vitrectomies are same. And as I said, it is multiple tenacious vascular. Because it's tenacious, you can't pull, otherwise break a problem. Or it's vascular, then you have bleeding. So answer is, solution is work very slowly and use scissors wherever possible. Patience, believe me, is the key. And if you pull too much, you will cause a lot of complications. And bimanual surgery, as I have been stressing, does work and help in a lot of these patients. And hemostasis is the key. And ultimately, for long term, this thing, full scatter laser is required. Even if you have done very good surgery, but at the end you have to do laser up to the ora serrata. And prognosis definitely, believe me, has improved by combinations of good machines, pre-op anti-VEGF, and a lot of good instrumentations have come now. Thank you very much for your kind attention.
Thank you, sir, for elaborating all the principles of vitreoretinal surgery. Any questions to Lalit, sir? Sir, do you give anti-VEGF injection before surgery? Pre-operative?
No, generally, I like to give anti-VEGF, especially if the look of the fronts is angry looking. But if it is whitish looking, I may not.
Then untreated cases with
but anti-VEGFs do help in reducing the per-operative bleeding, and also post-operative laser supplementation and rebleeds are much lesser.
So individualize the need for anti-VEGF.
Yeah, it's not 100% that all patients do require anti-VEGF.
But once you operate, do you give anti-VEGFs at the end of the surgery?
Generally not, but I have given anti-VEGF. Suppose I have caused a lot of bleeding, and I see a lot of vessels which are bleeding, because the scene is that whatever you leave at the end of surgery, first post-op day, you find more bleed than whatever you left. So therefore, if you have done massive surgery, if it's a simple surgery, it's okay, don't give. But if you have done a lot of dissection, then it may make sense to give anti-VEGF at the end of surgery also.
Treatment name cases.
Yeah.
Treatment name cases.
Treatment.
We are giving laser on the operating table. Probably it's okay because it takes some time for the laser to work.
Absolutely.
Framework.
Yeah, if it is unlasered previously, then you have done so much of laser, which will add to macular edema also. Plus, here and there small oozes, they also will be helped.
Even
Yes.
if you put oil, you give anti-VEGF at the end if it is.
Anti-VEGF is always given at the end only, because anti-VEGF I'll give when last port, 2 ports I have already closed. Just before the third port I'll give. Because if I do before, it may, elute out.
Sometimes in a phakic patient with vitreous hemorrhage, there's a lot of anterior bleed also. Just
Phakic.
filling the PC capsule, and that you realize intraoperative. You are not able to clear it without disturbing the lens.
Yeah.
And that causes the rebleeds in the post-op period. So
Yeah.
what to do then?
So here again you can consider, but you see, sometimes without touching you can employ more suction and try to pull this down. Yeah. Whatever is adherent, suppose this is the lens, you have only suction, pull it down, or do depression. Do lot of depression, and maybe you catch from the periphery some things which will, provide a play.
Of lens touch in bulky lenses, especially in
I know.
Actually, dense vitreous hemorrhage, you have very dense hemorrhage, both anterior and posterior. I think some of these cases are getting framework effect.
Yeah. So that is the third stage. But in case it's a simple vitreous hemorrhage. Yeah.
What I do is, sir, I do a phaco in the first sitting with the intravitreal injection. Take the patient after 3-4 days for the second surgery.
If you have to do a lot of membrane surgery.
But that is not possible to,
Anticipate.
pre-operatively.
And using red glow, like this cataract surgeons, it will help that vitreous, and use a little suction. It will.
Yeah.
You will
It
see
may
it better.
sometimes help. A lot of times it helps.
Yeah.
Or you wait, pass some time here and there, sometimes it gets loose and
Yeah.
you
Then
then
free if you do, then that area will clear.
Yeah.
So one question is, you mentioned about aspirin and clopidogrel.
Because I
would also
suffered
like-
once because this patient had so much of bleeding on the table and he was taking both this aspirin plus clopidogrel.
So
So only
clopidogrel,
aspirin. Yeah.
very.
Recently, I had one patient.
Aspirin, I personally stop for 3 days and clopidogrel 5 days. I do not know what others do because because clopidogrel has a life of
It takes
6.
1 month for the effect to go. So it's all, theoretical that you stop 5 days.
Literature says, as we said, 30 days is the washout period.
Yeah.
Stopping it 7 days before, scientifically it does not make a
Because when
the
we,
cause of bleeding might be a Abel's bleeder, a thick vessel. It might not be due to the anticoagulant.
Yeah. You see, the thing is, for major bleeder, we do not depend on anything else except diathermy. Because I don't believe laser can stop the bleeding.
so if the
Unless it's a
patient
very
is on aspirin and clopidogrel, would you prefer giving an anti-VEGF before? If the patient is on aspirin and clopidogrel, and you know that would an anti-VEGF before surgery might be a little protective?
Is this a substitute or two independent
I'm
things?
not a
of us?
substitute. I'm saying it might help you during surgery, and just a thought.
Depends
Next
on
time
the
I will ask.
cardiac condition also. No? If the patient is on multiple anticoagulants, cardiac condition also may not be
Yeah, that.
a triple vessel block.
But you see, stopping this for long term. Anti-VEGF may help you for some time,
Yeah.
but for long
During
term, because
surgery.
these patients, they are sick, per se. Usual diabetic patients who are well controlled may not bleed so much.
The new
Patients,
anticoagulants are they are using when the D dimer is high. Those
Yeah.
may be stopped, I think. That the new one, no?
Yeah, they are
That
that's what I
some
think.
this.
So thank you very much, sir.
Thank
I think we'll go on for paucity of time. Dr. Vishal will be talking on the approach to DME and not responding to anti-VEGF and role of steroids and vitreous surgery.
So thank you, Dr. Ajay, for having me in this course over the past many years now. And after anti-VEGFs, lasers, now I'll be talking of the role of steroids and vitrectomy in diabetic macular edema. So as we all know, it's a chronic multifactorial condition, DME. It causes visual impairment that critically impairs the quality of life in the working population. Anti-VEGF agents traditionally and still are the first line of therapeutic agents for the management of DME. But we know, and the literature also supports that around 40% of DME patients show more than 3 lines of visual impairment, only 40% with anti-VEGFs, suggesting the role of other factors besides VEGF in the causation and the pathogenesis of diabetic macular edema. It's a crowded slide, but the take-home message here in this slide is, besides VEGF, there are other factors which have now been proven, like ICAM, VCAM, selectins, MCPs, and interleukin 6, 12, and TNF, which are responsible besides VEGF for DME. So long-term responses to anti-VEGF therapy. So among eyes that showed limited initial visual improvement, limited, that is less than 5 letters, only 20 to 30% might increase in visual acuity over the long-term anti-VEGF therapy, following around 3-year follow-up period or 4-year follow-up period. So what is the current perspective on the role of inflammation in DME? I will not go very detailed into the trials, but there are increased levels, vitreous levels of VEGF, ICAM, IL-6 and MCP, higher in DME patients than non-diabetic patients. So the conclusion here is that the study showed that the vitreous levels of these pro-inflammatory cytokines had an influence on retinal vascular permeability and the severity of DME, not just VEGF but other cytokines also. So is dexamethasone or steroid effective in inhibiting inflammatory cytokines in DME? The next question is that. So again, there's the first evidence from the clinical trials setting. It says that the dex implant, whether it is in the trials, 0.7 mg was also used and 0.35 mg was also used, and both were better than sham in reducing the central subfield thickness. The second evidence is that when you switched from anti-VEGF to DEXA implant early, before 12 months, the vision improvement was much more. And even if you switch in the second year, the vision improvement is more than the anti-VEGF, but it is not more when you switch in the first year. So early switching is always beneficial in refractory edemas. So the question is, how many of us choose steroid implants early in DME care? We are always talking of anti-VEGFs. Why not dexamethasone implants or steroids? Because firstly, we are ourselves unaware of the suboptimal effect of anti-VEGF in our everyday clinical practice. We have so many anti-VEGFs every day. We do not compare the effect and the follow of the patients. We say that the CST is decreasing but the vision is not improving. It's okay, we'll continue with anti-VEGFs. Or are we concerned with the side effects of steroids, whether it is IOP rise or whether it is cataractogenesis? So now, definite guidelines, specifically from Europe, have come out. So where does dex implant fit into these guidelines? They have preferred, dexamethasone implant is preferred among corticosteroids. It can be used as a first line in pseudophakic eyes. It can be used as a first line in patients in phakic eyes with previous CV events. Can be used first line in patients unwilling to attend monthly injections or monitoring in the first 6 months, compliance problems. It is the preferred first line therapy in eyes with serious retinal detachments and DME, OCD biomarkers like hyperreflective foci, many hard exudates, chronic DME, or neurosensory detachments. So the bottom line here is persisting to single treatment modality like anti-VEGF when it is not responding is not guaranteed to success. On contrary, it delays the effective treatment, resulting in the final visual outcomes. Steroids for treatment naive patients, well, that is controversial, but now literature supports that pseudophakic or phakic eyes that are not young, clear or crystalline can be given first line treatment. Poor treatment adherence or compliance or DME with suspicion of a high inflammatory component like hyperreflective dots with neurosensory detachments and not suitable for anti-VEGF therapy because of some systemic condition. So the key takeaways of steroids in DME is, of course, the first line of treatment still is anti-VEGF agents, and many patients who fail to show the usual response to anti-VEGF, even with intensive treatment, you should look for an inflammatory pathology, and intravitreal corticosteroids block that production of VEGF and other inflammatory cytokines. And dexamethasone implant shows efficacy in the treatment of DME along with a favorable safety profile. Coming to the last topic, that is vitrectomy for diabetic macular edema. So again, there are two schools of thought that it works, it does not work. So let's categorize it. First is the tractional DME. Of course, there is a definite role of vitrectomy because in tractional diabetic macular edema, the tangential traction and the anterior posterior traction is causing that macular edema. It's a physical thing. So it includes vitreomacular traction, it includes taut posterior hyaloid membrane, epiretinal membranes, and no amount of anti-VEGF or steroids will help in these cases. You have to remove the physical force which is causing the traction. Second is a relative indication, that is recalcitrant macular edema. By definition, if you have given 4 or 5 intravitreal anti-VEGF, switched on to alternative therapy like intravitreal steroids, and still the edema is persisting over a period of 6 months or more, that classifies into recalcitrant macular edema, and that is a relative indication for PPV. All the studies which I have done and our personal experience shows there is excellent anatomical results with reduction of central subfield thickness and restoration of a normal foveal contour in all these vitrectomies. So, a couple of short clips. So this is a patient of taut posterior hyaloid membrane causing a persistent macular edema. The crux here is to stain it again and again because there are multiple layers before you reach the internal limiting membrane. So you stain with triamcinolone acetonide. You can see a thick sheet which is the taut posterior hyaloid membrane. You cannot take it out with a cutter. You have to peel it like ILM. Of course, it's different in consistency than the ILM. It is more thick, it is more tenacious, but gently you remove it. Then comes the epiretinal membrane beneath it. You stain it with trypan blue, then you peel it in the routine fashion, and finally you stain it with brilliant blue, and then you catch hold of the ILM. So there are 3 layers which are stained with 3 different dyes, and this is the final layer of the ILM which I'm peeling here, and it gives satisfactory results in terms of OCT contour of the fovea. The visual outcome depends on how long that TPHM has been there, how long the traction has been causing that edema. There are 2 short clips, 2 different case scenarios of recalcitrant edema, macular edema. So this was a patient who had underwent multiple injections of anti-VEGFs. The edema was still there, and it's a laser PDR, and a routine ILM peeling has been done, and the patient did fine. He required multiple injections after that, but they came down to 2 to 3 per year and caused a reduction in CMT. This one had a lot of cystoid spaces, and the roof was very thin, so I was afraid that I would de-roof and cause a macular hole. So I did an inverted ILM peeling here and trimmed the stumps so that not to de-roof the fovea and cause a macular hole. The patient did fine in the post-op period. So to conclude, indications of PPV in DME or PDR keep on evolving with time, and the extent also. Any diabetic vitrectomy, whether it is for vitreous hemorrhage or for DME, is not a straightforward procedure, and complications can happen. And data is inconclusive for PPV in treatment naive-wise. And despite, I have mentioned it twice also, the central subfoveal thickness does reduce, the foveal counter does get in shape, but despite the best anatomical postoperative outcome, vision gain is modest in many cases. Thank you so much.
Thanks, Vishal. I think for paucity of time, we have 2 more speakers. Dr. Giridhar, so while he is putting his this thing on, Dr. Giridhar will be speaking on vitreoretinal surgery in PDR, timing, technique, and tips. Surprises, yeah. So while he is putting on his presentation, one question, Vishal, that many times when you do a peel of the membrane, after a month or 2, you realize the macula actually has become thinner.
Yes,
it becomes so.
That's what I'm telling you. The more the thickness is, more the chances it gets thinned
Down.
in the post-operative.
Yeah. So do you tell the patients beforehand that it might?
These patients are already on chronic anti-VEGF therapy without an improvement, so the expectations are not much. That's at last ditch effort.
So my topic is surprises after cataract surgery in eyes with diabetic retinopathy. We are all aware that in any patient who's going in for a cataract surgery with underlying diabetic retinopathy, there are 2 or 3 things that we need to do. One is to see whether the defective vision is primarily due to the cataract or primarily due to the diabetic retinopathy. I think this is very, very important. And this is possible unless and until the cataract is very significant and we are not able to make any proper assessment of the posterior segment. Otherwise, today, I think most people operate on cataracts quite early, and therefore, I think in most of the cases, so it's very important. So some of the things that have been told already, like the OCT, careful examination of the optic disc is very important in diabetic patients with retinopathy because previous history of non-arthritic optic neuropathy is one of the very common causes of unexplained visual loss in patients who undergo cataract surgery in underlying diabetic retinopathy. So having said that, I'll just share with you some 3 or 4 cases, and with that we can just give you some messages. So these are all patients that have been treated in our hospital over the course of the last 8 to 10 years. And I think I made this presentation in the AIOS in the previous years also. So this is a very old case, but why I should be so old cases is these are patients with long-term follow-up who have been under our care for many, many years. So this gentleman came with a visual acuity of 618, 624, known diabetic on treatment. This is the fundus photograph, and he also underwent. So whenever we see diabetic retinopathy in patients with cataract surgery and the media is reasonably good, it would be advisable to complete all investigations prior to cataract surgery, including OCT and, if necessary, fundus fluorescein angiography, because you will know whether he has got a treatable retinopathy or he has got a non-treatable retinopathy. That is a retinopathy that does not require any treatment. So this patient has got something like a CSME, suspected CSME in the right eye. So the patient underwent multiple injections. Now you can see the visual acuity has further deteriorated because of the advancement of the cataract. And at that point, these are all very old cases. That's why we have given bevacizumab in some of these patients. So at the time of cataract surgery, we also give 1 shot of bevacizumab, because that is the protocol in our hospital, because cataract causes intraocular inflammation, and most patients have an exacerbation of the diabetic macular edema. So it would be advisable, even though the edema is very minimal, to give 1 shot of anti-VEGF at the time of the cataract surgery. So this patient underwent multiple injections after cataract surgery. One need to understand that unfortunately, some cases of diabetic macular edema behave in a very, very difficult way after cataract surgery. There is significant worsening, as you can see in this particular case. And this patient again was treated about 10 to 12 years ago when Osutex was not there, and that's why he received Triamcinolone. The reason why we gave Triamcinolone is because of the significant edema, serious macular detachment, systolic changes. And of course, with 1 dose, he did improve. And if you see the initial picture, now if you see this sort of picture, you know that these are patients who like to have a lot of microaneurysms, and therefore you do the fluorescein angiography. And after the 1 edema, let's give perifoveal laser photocoagulation to the microaneurysm. This is a must, especially in patients who have got cercinates. They do extremely well with laser photocoagulation. But unfortunately, this patient again had a recurrence and again received 1 more shot of triamcinolone, and again did the fluorescein angiography, and residual microaneurysms were treated. So the take-home message is pre-existing DME can worsen following cataract surgery. Although you might have treated this DME prior to the cataract surgery, there's a possibility of worsening, and therefore you need to keep this in mind when you hand these patients. Now this is a patient who had a center-sparing DME. You can see the red color that's not involving the fovea. So it was a center-sparing CSME with a normal fovea, and therefore this patient in those days underwent just a phaco. But unfortunately, again, immediately after phacoemulsification, within 6 to 8 weeks itself, the patient came with a drop in vision, and there is significant CSME. And the patient again underwent triamcinolone injection, and again fundus fluorescein angiography was done. And this patient again received perifoveal laser photocoagulation, because these types of CSME, where you see cercinates and hard X-rays, focal microaneurysms will be there, and they respond very well to focal laser photocoagulation also. So this patient had 2 sittings of perifoveal laser photocoagulation with multiple sittings of anti-VEGF and triamcinolone 1 or 2 doses, and with that sort of an intensive treatment. Now this is very, very important. These patients have to be treated intensively, and once you do that, in many of these cases, you do see significant improvement and stabilization of vision, and also stabilization of the diabetic macular edema. Now this patient, after multiple injections, multiple doses of focal laser to microaneurysms, finally his macula settled, and I have a follow-up of about 8-10 years. He still remains quite stable now with a reasonably good visual acuity of 6/18 and 6. That means his diabetes is under control, and unfortunately the cataract surgery resulted in worsening of the diabetic retinopathy. Now in the left eye, I changed the treatment. Since the right eye behaves so differently, I thought, okay, left eye, let me treat the DME again prior to surgery. But in spite of treating the DME prior to surgery, In the left eye also, the behavior was worsening of the DME after cataract surgery, and a similar treatment was given to the left eye, and he finally responded with a reasonably good visual acuity of 624, 636. You can see the left eye, how it was immediately after the cataract on the top side, and on the bottom side you can see the hard X-rays have significantly decreased. Therefore, I would like to say that the center sparing DME also in patients with underlying cataract should not be taken lightly and should be intervened prior to surgery. Probably focal laser photocoagulation can be given to the microneedles prior to surgery if it's possible, and preoperative OCT, of course, is important, and immediate postoperative retinal examination is important. Now, the third case is indeed a very interesting case. This again is from our own hospital. This patient was treated in the community section. This patient underwent cataract surgery in the right eye and left eye in a short gap, and with diabetes of 12 years duration. Visual acuity fantastic, 6/6. But she had moderate non-proliferative diabetic retinopathy, but unfortunately the patient was not referred to the retina clinic. The patient came back even after a month or so. Imagine, the patient has been careful. I mean, the patient probably had slight blurring of vision. Again, it was seen in the outpatient department. Everything has been documented in the chart, severe NPDR, but no color photo, no fundus fluorescein angiography. And finally, July 2020, within a matter of 3 months, the patient comes with a drop in vision with a dense vitreous hemorrhage in the right eye with a visual acuity of CF 2 meter. So what we learned from this particular case is, number one, it was not managed properly. So once you see severe non-proliferative diabetic retinopathy, it's important to at least send it to the retina clinic, or at least do a fundus fluorescein angiography to see whether there are subtle areas of retinal neovascularization, and give adequate laser photocoagulation immediately. So this could have been a preventable situation, and you should always remember that even ischemic processes do worsen with after cataract surgery, and we have seen cases even of proliferative diabetic retinopathy who have had adequate laser photocoagulation, and where we expect good visual acuity, who improve initially, but unfortunately posterior vitreous separation starts after cataract surgery, and that causes a tractional retinal detachment and worsening of visual acuity. So you can see the color photo, and you can see the fundus fluorescein angiogram. There is a definite disc neovascularization, and although this patient was treated with laser, etc., visual acuity in both the eyes deteriorated, and there was a worsening of the retinopathy rapidly in both the eyes, requiring surgical intervention. So possibly, in spite of laser, this might have happened, but nonetheless, this probably could have been prevented to a certain extent if we had made an early diagnosis. The last complication which we notice in patients with diabetic retinopathy and cataract surgery is neovascular glaucoma. Unfortunately, I could not track any particular treated case from a hospital, but one should always remember that some of these patients with proliferative diabetic retinopathy who have dense cataract, you do a cataract surgery because VEGF levels increase after cataract surgery. VEGF levels increase in the anterior chamber, and therefore they come to you with neovascularization of the iris and neovascular glaucoma. We have had many, many cases like that, and these cases have to be treated early and aggressively. And if you do that, some of these patients do regain reasonably good visual acuity. Thank you all for your kind attention.
Thank you, Giri. That was very good messages. We can have Dr. Ritu's presentation and then have a question. But because they're similar, so Dr. Ritu will be talking on cataract surgery in DME and PDR, anterior segment surgeon's perspective.
A very good afternoon to all of you. Thank you, Dr. Ajay, for including me in this IC. And it's been a very popular IC, I think, for the last couple of years. I'll be talking about cataract surgery in diabetic macular edema and PDR and optimizing the outcomes. Already my previous speakers have given you a good idea about how you need to stabilize the retina before you go ahead for cataract surgery. And just some facts that cataracts are 2 to 5 times more frequent in diabetics, and cataract can develop very rapidly in diabetics. Also, with so many intravitreal injections, these patients can develop cataract. It occurs at a younger age, and in fact, almost 25% of all our cataract patients are diabetics. Now, to optimize the visual outcomes of cataract surgery, diabetic patients, irrespective of whether they are, early NPDR or they're just diabetics without NPDR or PDR, they need special attention. Now, the indications of cataract surgery could be an advanced cataract. So you do have poor visualization of the retina. You need to monitor these patients carefully. It could be as part of your vitreoretina surgery where the cataract is significant enough so that the vitreoretina surgeon does not have a good view. Or it could also be patients who have associated glaucoma. Now, what are the main concerns? The main concerns where, as Dr. Giridhar has also specified, is the post-op CME, which is much more frequent. There's a worsening of the diabetic macular edema. There could be progression to PDR. And these cases are definitely, they have much more increased inflammation. There's also a risk of infection in poorly controlled diabetics, and these could be patients who may end up in endophthalmitis. And these surgeries are generally challenging, especially if they've already undergone repeated intravitreal injections or a VR surgery, and they do need more experienced hands. Now, we need to manage the comorbidities preoperatively, intra and postoperatively. Preoperatively, it's extremely important to manage the systemic condition because these patients could be having an associated nephropathy, they could be on dialysis, we need to avoid nephrotoxic drugs, they could be having associated cardiac problems, they could be on blood thinners, they could be hypertensive. So all these things need to be asked, a detailed history should be taken. They could be have neuropathy or vasculopathy. And coming to the ocular examination, a detailed anterior and posterior segment examination should be done. A metabolic control has not been spoken about, but having a good metabolic control is extremely important, and generally the advice is to have blood sugars less than 140 and PP less than 180, which is not always very easy to attain, and so we need to sometimes be patient and associate with the diabetologist so that your patient is well controlled. So this just shows a photograph of a patient who had NPDR, which is center involving diabetic macular edema, and just with the good systemic control, the retina looks so much more better. And now only we can go ahead for the cataract surgery a year later. So preoperatively, reducing, controlling the diabetes is important, but at the same time, we have to know that a sudden reduction in your HbA1c can actually cause a worsening. So although you want to reduce HbA1c, it's better for the patient on a whole, but at the same time, we also know that a rapid correction can actually cause a worsening of the maculopathy, can lead to progression to irreversible PDR. So one needs to be a little more cautious on how, your diabetologist may not have any clue about it. He thinks sugars have to be controlled and they just put the patient on insulin and cause a rapid reduction. But that is not the way forward. So a detailed anterior segment evaluation, because these patients could have inflammation, they often have a lot of ocular surface disease which needs to be managed before you go ahead for surgery. A careful examination for iris neovascularization, because often these patients come to you dilated. So we may miss that on slit lamp examination. So it's important to see them undilated too. And look for glaucoma, look for the pupil dilation, because they're often poorly dilated patients and that can make your surgery more complicated. Doing a specular, looking for the endothelial dysfunction. Also, these patients who've undergone repeated injections could have zonular instability, so we need to be prepared for that. So diabetics, as Dr. Girdhar also mentioned, they have higher inflammatory mediators, and so preoperatively you must settle the patients by starting them on NSAIDs. Normal patients, I would start with 2 to 3 days preoperatively, but diabetics, it may be better to start them at least 1 week preoperatively and continue the NSAIDs for 4 to 8 weeks post-op. So manage the ocular surface. They often have meibomitis, blepharitis, and delayed epithelial healing, and an unstable tear film can also make your keratometric readings and your biometry a bit unreliable. And as I already mentioned, look for NVI, and these patients may need to have an anti-VEGF injection preoperatively. look for associated glaucoma, and patients who are well controlled, who are on single medications, you may plan only for cataract surgery. But those who are on more than 3 medications, they may require combined surgery. And now, we are moving from trabeculectomies towards MIGS, and which is much more less invasive and is giving reasonable good outcomes. You can combine it with your cataract surgery, and you're also saving the conjunctiva for a future trab if at any time it is required. Earlier PG analogs used to be discontinued, but now I think most glaucoma specialists do continue with the PG analogs. So, but evaluating the disc is important. Often what happens is, you're so focused on your diabetic retinopathy that you actually miss evaluating the disc. So taking a good disc photograph and documenting is a good idea. Thorough posterior segment evaluation should be done, and even if you're just an anterior segment surgeon who has a busy cataract practice, nowadays we do have good fundus cameras available. So taking your fundus photograph, associating with your retina colleague, taking their opinion not just pre-operatively but also post-operatively, they must continue with their retina assessment. And documentation is important. Now that we have the wide field fundus photographs, OCT angio, B-scan, etc., we should be doing that. And it's medical legally important also. So if you find that the patient has some diabetic retinopathy, then the treatment, if possible, should precede your cataract surgery. Now, of course, the intervention will depend upon what is the stage of the diabetic retinopathy, whether it's mild, moderate, severe NPDR or PDR. And I will not go into too many details because you've had an exhaustive session on how to manage all these problems. But if the patient does not have diabetic retinopathy, mild to moderate NPDR, you can do an early cataract surgery. And as already specified, you can go for focal lasers, anti-VEGF as the indications are. And in PDR cases, you often have to do a combined surgery, or you may do cataract surgery with an anti-VEGF initially and then follow it up with a vitrectomy. Now, the studies have shown that there's a significant increase after even uncomplicated phaco. The macular thickness can increase at 1, 3, and 6 months. And so again, stabilizing these patients and also discussing and counseling these patients. Because unless you tell the patient that they have to come for frequent examinations, it's not the end of it after you've just done a cataract surgery. And you also have to give them a prognosis that these possibilities may occur, and that can reduce the chances of patient dissatisfaction. So intraoperatively, the challenges are the poor pupil dilation, the endothelial dysfunction and the instability, and we need to be ready with good viscoelastics, doing a soft shell technique, reducing your phaco power, being ready with the pupil expanders or CTRs if required, and of course the lenses that careful biometry also, especially when you're having patients who've undergone vitrectomy who have silicone filled eyes. And we generally prefer to choose hydrophobic lenses. You also have heparin coated lenses. Now the choice of lens usually used to be a monofocal, but now yes, we do have EDOFs available, and those who are good well-controlled diabetics who have relatively good retina, you can go for extended depth of focus lenses too. Of course, ACIOLs, iris fixated lenses, should be avoided. So you may prefer a peribulbar anesthesia in these patients. The rexus size should be very optimum, because remember that we do not want to have capsular phimosis. We want to examine the retina post-operatively. Use a soft shell technique. Avoid a hydrodissection, especially in posterior vitrectomy patients who have a posterior subcapsular cataract soon after vitrectomy. These patients could be having a PC defect, and you may end up having a nucleus drop. The zonules are weak, so you may have to use a CTR, and capsule polishing and a meticulous cortical cleanup is very important, because you don't want to do an early YAG in such cases. Again, having an IOL in the bag and removing all the viscoelastic to prevent a post-op IOP spike and reaction is again important. If you're going to be combining with vitrectomy, or you think the patient may require laser post-op, then it's a good idea to suture your incision. And post-op management, it's important to give control the inflammation, give an aggressive topical steroids and NSAIDs. A lot of lubricants are required in these patients because they have ocular surface diseases. Manage the glaucoma and avoid early yak. I know I'm getting late. We are, I think, overshot our time. So the take-home message is that with modern techniques and well-controlled diabetics, stable retinopathy, the overall visual outcome is good. But a good preoperative management of the comorbidities is important. You can plan an early surgery before before your retina view becomes hazy, and a frequent post-op fundus examination is important. And managing the macular edema both preoperatively and in the early post-op period is critical, as these patients are at increased risk of retinopathy and progression after surgery. Thank you so much.
Thank you, Dr. Ritu. Actually, when cataract surgery is combined with retina surgery, there are a lot of things that we should be careful, because sometimes after prolonged vitreous surgery, the cornea will become hazy, the wound will start leaking. So intraoperatively, the cataract surgeon, we do combined surgery with a cataract surgeon. We don't do both together. Sometimes we put a suture at the tunnel so that it doesn't leak, and at the end we can remove it, or even Vicryl suture can be put so that it doesn't leak during the manipulation inside. The thing is, sometimes the cornea will become hazy during vitrectomy. It may take 1 hour. Once upon a time, it used to take hours. Then usually it ends up with removal of epithelium and all. But now, because of the advanced techniques, we don't take that much time. But we try to finish as early as possible after the cataract surgery.
I'll just take 2 minutes because Dr. Rajiv Raman couldn't make it. I got his presentation. So it's very interesting work which is being done on AI and diabetic retinopathy. So essentially want to tell you that AI has changing a lot of things. It has a lot of predictive values, and what they are trying to do is to detect the thickness of the retina just based upon fundus imaging. So that what OSTI can give you, AI can give you on fundus imaging. This is just some thoughts for you. This is too complicated matter, which I think Rajiv, if it had been here, it would be very good. So with AI, we can define centers involving diabetic macular edema extremely well by fundus imaging alone. And these are some of the results which they have shown, and they were very predictive. Then they say that there is a predictive presence. By just looking at the pupil, you could predict whether the patient has diabetic retinopathy or not. So this is again something new that is happening, and we would know more as time goes by. A lot of work is being done between Shankar Nethralaya and Google, and with good predictive value. So I will not take your time. They are trying to, this is just to show you his presentation. And predicting OCT response to treatment. There is, again, they're doing some work which is basically showing that if by looking at the OCT pictures, can we predict how the patient is going to respond to various therapies that are available. And a lot of deep learning is being put in. Approach to learn from how to define that a particular patient would benefit more from steroids or anti-VEGF is again being put in with AI-based systems. So once these systems are well in place, I think we won't lose our work. Not that the AI would make us jobless, but I think it will help us improve our specificity and output and make our treatment probably better. So I would like to conclude here by, and this is also they're trying to show how to detect neuropathy just by looking at various fundus photography. which patient is going to develop an optic neuropathy, that is also being assessed by AI. So there are a lot of work which is happening. So this is just to share some thoughts, and want to thank on behalf of Rajiv that he has a huge team which is working on giving us the futuristic plans of how AI-based interventions can be done in diabetic retinopathy. And I thank you all for all those who attended the course, stayed back for till the end. Maybe we have just 3 speakers, but let's have all the participants come here. Let's have a group photograph. Come.